So good evening, friends, and we meet again today on this platform of MedCAS. And thank you, Sanket, for approaching me again. Today we'll be taking a small topic of approach to peripheral neuropathy. As a medicine resident, and I'm sure as a clinician also, you will come across many patients who suffer from a variety of sensory symptoms, and majority of them will turn out to be peripheral neuropathy. But peripheral neuropathy, I should say, I'm not saying it, my teacher used to teach us that way. So he used to say that peripheral neuropathy, it may be a neurological disease, but you should be having a very sound knowledge of general medicine if you want to take a case of peripheral neuropathy in exam. Because although the symptoms can be neurological, the evaluation, the examination, investigations and treatment, they can all go into general medicine. And therefore, I'm sure you people will definitely enjoy this talk. And I'll just touch upon a few basic points and how to approach, how to proceed when you come across a patient who has neuropathic symptoms. So peripheral nervous system, we all know the nervous system is divided into two main portions. One is central nervous system, which is brain and spinal cord. And then comes the peripheral nervous system. The peripheral nervous system, it starts from the neurons, that is a cell body. Then the nerve fibers which emerge out from the neuron, they are called the root. Then comes the plexus, which is the conglomeration of all these roots. From the plexus, independent nerves will emerge out and will go into the respective areas. So they are called the peripheral nerves. The peripheral nerves will terminate over the muscles, and the joint or the junction is called the neuromuscular junction. So starting from the cell body, the neuron till the muscle, this entire pathway is called the peripheral nervous system, or in other words, lower motor neuron pathway. And the main function for these parameters or these structures is motor function, that is muscle movement, touch, pressure, pain, temperature, proprioception or joint position, and autonomic functions. So these are the primary functions which are governed by these modalities. And peripheral nerves are very widely distributed in the body, right from the head till the toe. In other words, we would say wherever there is skin, there are peripheral nerves. So they are one of the most vulnerable, and they are very commonly affected subset of the neuroaxis. And there are particular reasons for that. First of all, as we said, it is widely distributed throughout the body, so it can be affected in any of the areas. Secondly, many of the points are such that the nerves are exposed in a way that they are not protected by any bony environment or a bony structure or within the muscles. For example, the ulnar nerve at the cubital tunnel. So that is one area where the ulnar nerve is just adjacent to the skin, and it is just in contact with the bony structure, the olecranon process. So there are many points in the body where the nerves are in a way exposed to external pressure or other insults, and hence they are more vulnerable to disease. Next is the nerve physiology is very, very meticulous, very dynamic, and they require an optimum internal environment for its normal physiological function. And they can be very easily affected or vulnerable to external pressure, oxygen depletion, blood depletion, that is ischemia, any metabolic changes like blood sugar changes, any infections or inflammation, and drugs as well as toxins. So because of these main reasons, the peripheral nerves are a very easy target and very commonly affected in any neurological issues. So broadly, peripheral nerves can be, peripheral nerve disorders can be divided into two portions. One which affects the cell body, it is called the neuronopathy. And neuronopathy again can be subdivided as motor neuron affected, that is called the anterior cell disease, and the sensory neuron being affected, called the dorsal root ganglion. And the other portion is the nerve fiber or the nerve filament which is affected. It is called the neuropathy or the peripheral neuropathy, which we commonly understand. And peripheral neuropathy then further is subclassified as being small fiber neuropathy or large fiber neuropathy. It can be myelinated neuropathy or non-myelinated neuropathy. And it can be motor nerve involvement, sensory nerve involvement, or autonomic involvement. In majority cases, it is a mixed picture of all these things. So this is the basic classification. Now let us come to the symptoms. Like what are the basic symptoms that the patient will report? So neuropathy symptoms can be classified as positive symptoms and negative symptoms, and those with sensory, motor, or autonomic functions. So whenever the patient comes and reports you something related to tingling or numbness or paresthesia, these are all very technical terms, but your job is to classify them into positive or negative phenomenology. So here we will just see what are the positive symptoms. So in sensory, the positive symptoms are pain, burning, tingling, paresthesias. So these are all not loss of functions. These are gain of functions or overactive nerves, and they will result into positive symptoms. In motor, what happens is there are muscle cramps and fasciculations. These are the positive motor symptoms. And in autonomic system, hyperhidrosis, that is excessive sweating, or diarrhea, that is excessive GI motility. On the other hand, negative symptoms. So negative symptoms are related to loss of function. And in this, we will see numbness, which is loss of sensation. There can be loss of joint position or proprioception, and leading to postural instability. In motor, we will have the classical motor weakness, that is muscle weakness, and there will be atrophy, muscle atrophy. Remember, muscle atrophy is a negative symptom. It is a loss of function of the muscle. And in autonomic symptom, there will be orthostatic hypotension, loss of sweating, erectile dysfunction or impotence, and constipation. So these are broadly categories of how the patient will present to you and how you are supposed to classify the symptoms into positive and negative. How is it important? That we will come to see in later slides, but for now, you just keep this in mind. Now, once the patient presents itself with a particular symptom, let's say tingling or numbness in feet. So then the first job is, as a clinician, to localize that this tingling and numbness is originating from a lower motor neuron system. We have previously seen what is lower motor neuron system or what is peripheral nerve system. So basically, your examination first of all should target to localize on the peripheral nervous system. There should not be any upper motor neuron signs or symptoms. So which are the hints or pointers which will tell you that this is a peripheral nerve system problem? So first of all, muscle tone should be either normal or reduced. Secondly, there should be or there may be evidence of muscle atrophy or wasting. Next is muscle weakness, which occurs in a pattern of a particular nerve or a root. That is, for example, if the median nerve is affected, you will find that there is a muscle weakness involving all the muscles which are innervated by median nerve. Or there is a C6 root affection. So in that case, you will find the muscles are weak, whichever are supplied by C6 root. So that way you should have some knowledge, basic knowledge about the myotomes and dermatomes. Again, sensory loss is demonstrated in a particular nerve zone or a root distribution. Reflexes are either normal, reduced, or absent. And most importantly, there might be differential sensory involvement. So patient may report normal joint position and vibration, but impaired touch or pain modalities. Or the other way around, the patient has impaired joint position and vibration, but have normal touch and pain sensations. So whenever you have this type of differential pain or differential sensory involvement, it is usually in favor of a peripheral nervous system. And there are a few diagnoses which will create confusion in a peripheral neuropathy patient. And these are the list of these diagnostic dilemmas. If you see closely, most of them are pathologies which are related to spinal cord. So spinal cord disorders are very, very close mimics of a peripheral neuropathy. And your job as a clinician is to rule out or rule in a spinal cord disorder whenever the patient presents with a neuropathic symptom. Now, red flags in peripheral neuropathy means it is a warning sign. This is not peripheral neuropathy. So when you are examining or when you are taking a history of the patient, you should keep these points in mind. If any of these appear in your history or examination, you should have an antenna to catch that. You should be aware of this point that this might not be a pure peripheral neuropathy. There is something else also which is going on. So first of all, it is spasticity. Patient presenting with tingling or numbness in his legs, and he has a hypertonia or spasticity. It rules out peripheral neuropathy. So your examination, when you're examining this patient, it is very important you examine the tone of the affected limb. Next, plantar extensors. So extensor plantar is a promoter neuron sign, and it should not be present in a patient who has pure neuropathy. Again, reflexes being brisk, hyperreflexia, it points towards upper motor neuron involvement. Patient complaining of a hemi-body symptom. For example, right hand or right leg or both of them, they are getting affected with paresthesias or numbness. Especially involvement of a half side of the face. It is a very short indicator. It is not a peripheral neuropathy. So you should keep this in mind, the hemi symptoms. Prominent bladder and bowel involvement. especially in the initial part of the disease. So when the symptoms are starting and within few days or weeks of the onset of symptoms, if the patient is presenting as bladder history or a bowel incontinence, that usually doesn't go in line with peripheral neuropathy. And on examination, if you are able to find a sensory level that is a horizontal sensory level, and usually a horizontal sensory level indicates a spinal cord involvement, and it is against the diagnosis of peripheral neuropathy. So these are basically your red flags, and this is very important to be remembered, maybe not theoretically, but in your practical case presentations and also in your clinical practice. So once we confirm that the patient has peripheral neuropathy, there is no other system which is involved, then your next step should be answering these sort of questions. The first question being, which are the systems involved, sensory, motor, etc. Next should be, if there is a motor involvement, what is the distribution of weakness, whether it is distal, proximal, symmetrical, asymmetrical. Next is, what is the nature of sensory involvement, whether it is peripheral, touch, pain, temperature, is it that same? If there is a prominence of positive symptoms or negative symptoms. Then is there any evidence suggestive of associated upper motor neuron pathology? What is the temporal evolution? What is the course of illness? Is it acute, subacute, relapsing, remitting, chronic, etc.? And if there is any pointer which is marking a hereditary etiology. So if you are able to answer these 6 questions, then I'm very sure that you will have a very confirmed and a very sure diagnosis of a peripheral neuropathy, and it will be very easy for you to present it as a case, especially in your final exams. So before jumping on to the questions, let us first understand what is a peripheral nerve prototype. So I'm sure many of you must have seen this picture and must be aware of this type of pattern. It is commonly called the glove and stocking pattern. And also it is called the length-dependent neuropathy. Now, what is length-dependent neuropathy? So length-dependent neuropathy means that the longest nerves are affected first, later on getting involved by the other nerves which are shorter in duration gradually. So the longest nerve anatomically are those which go down into the feet. They start from the lumbar roots and they will go down into the feet. So the length of the legs is more than the length of the arm anatomically. And hence in length-dependent neuropathies, the patient will always present with lower limb symptoms first because they are length-dependent neuropathies. The symptoms will gradually ascend from toes into the feet, into the ankle, into the mid-shin area. Once the symptoms are up to mid-shin area, the patient will then start having symptoms over the fingertips. And from fingertips, they will ascend upwards to involve the palm, the wrist, and forearm. And accordingly, in the lower limb also, from mid-shin, it will ascend upwards and go into the knees or mid-thigh area. So that is how the progression happens. But very importantly, the onset occurs from the tips of the fingers or sole of the foot. And whenever you come across this type of history or this type of pattern, if you go back into the history meticulously, you will definitely find this type of onset and progression. And it is very important to find this out because it has got clinical implications that we will see later in the slides. But basically, you should remember glove and stocking pattern, length-dependent neuropathy. Whenever you come across a length-dependent neuropathy, it is always an axonal damage. And it, as we said, it goes from lower limb to upper limb. Majority of the cases are chronic in duration. They are slow progressive. It goes on over weeks or months. They are not acute. Most of them will have a sensory symptom or sign which is dominant. Motor symptoms or sign are not very predominant or symptomatic for the patient. And in sensory, you will have more of positive symptoms rather than negative symptoms. Positive symptoms as in pain, burning, and paresthesia, rather than loss of sensations or gait imbalance. The classical example for this is diabetic peripheral neuropathy. Now the question which comes first is which system is involved. So we know sensory nerves, motor nerves, and autonomic nerves, and we have sensory positive and negative symptoms, motor negative and positive symptoms, and autonomic symptoms. So you should be familiar with the particular symptoms of sensory, motor, or autonomic areas. And in history as well as examination, your job is to find them out either on direct questioning, either on examination. Now, commonly the neuropathies are sensory in nature. Most of them can be pure sensory or it can be sensory motor with sensory dominance. But there are few examples where patient will have pure motor neuropathy. And this is a very important Viva question. This might be asked in your Viva, as in your long case Viva. And clinically also, it is very, very important to know these entities because they do make a diagnostic and treatment difference. So pure motor neuropathies, AIDP and CIDP, that is GBS varieties, acute or chronic. Then porphyria, lead toxicity, hereditary motor neuropathy, multifocal motor neuropathy with conduction block, and depson toxicity. So these are the common ones which we see in day-to-day practice, and they are affecting purely motor peripheral nerves. In the same way, you have isolated autonomic neuropathies where the patient will complain of dominantly the autonomic symptoms, and they are diabetic mellitus, sarcoidosis, amyloidosis, HIV, paraneoplastic, hereditary autonomic neuropathies, GBS, and alcoholism. So these are common examples where autonomic nerves are predominantly involved, and at times they are very difficult to diagnose because they do not have that classical tingling and paresthesia type of symptoms. They will have present with some vague and non-specific, non-neurological symptoms. And most important, with cranial nerve involvement. It can be isolated cranial nerve, it can be multiple cranial nerves at the same time, which is called polyneuritis cranialis. So diabetes mellitus, GBS, HIV, sarcoidosis, neoplastic infiltration, paraneoplastic, and diphtheria. These are the common examples which may present with cranial neuropathies. Cranial neuropathies can be in isolation or it can be accompanied by the other peripheral neuropathies of upper or lower limbs. Next comes is distribution of weakness. So if the patient has either on history, there is a history of weakness, or you on examination are finding it that there is a motor weakness. So then you should be able to tell whether the patient has got a distal weakness or a proximal weakness or both. Conventionally in peripheral neuropathy, there is a distal weakness. Chronic neuropathies are more associated with muscle wasting. So you should be observant about muscle wasting, especially when you are examining the patient. Exceptions are there where neuropathies will come as proximal muscle weakness also. We will see that in later slide. And next job is to find out whether there is a symmetry to the presentation or there is an asymmetric presentation. So asymmetric presentations are usually mononeuropathies, that is single nerve involvement, or it can be a mononeuritis multiplex where multiple nerves are involved at different time durations. Whenever you come across an asymmetrical presentation, in peripheral neuropathy, usually it rules out any toxin or hereditary or metabolic etiologies because these are classically presenting over as a peripheral neuropathy which is of symmetric type. And in asymmetric pattern, you should also think about anterior-horn diseases, about about radiculopathy or roots, and as a plexopathy or plexus involvement. So these are the list of neuropathies which come as a proximal weakness. AIDP or GBS, CIDP, diabetic plexopathy, porphyria, paraproteinemia neuropathies, arsenic neuropathy, and lymphoma leukemia infiltration. So these are the entities which may come up as proximal weakness. They look like myopathy because they will have difficulty in standing and sitting standing and sitting, or by climbing up and down the stairs. So these are the symptoms usually associated with myopathy, but these neuropathies will mimic like myopathy. And then we have asymmetrical neuropathies, which can be focal, single nerve involvement, or it can be multiple involvement. So focal involvement can be because of an entrapment in a soft tissue or a bony canal. It can be compression, it can be traumatic, it can be ischemic, leprosy, sarcoid, diabetes, and neoplasm. And multifocal can be again diabetic, vasculitis, sarcoid, infective, lymphoma. There is a variant called MADSEM variant of CIDP, multifocal motor neuropathy, and hereditary neuropathy with pressure pulses. HNPP, it is an exception to hereditary neuropathies. Classically, hereditary neuropathies are very much symmetrical, very slow. They have that what we say indolent course over years, and more or less they do not have disability as such. HNPP is an entity where patient will have recurrent isolated neuropathies. It can involve at one time, let's say, ulnar nerve. Sometimes it will involve the peroneal nerve. At times it will involve carpal tunnel, as in median nerve. So patient will present with isolated neuropathies, and it will be like a relapsing remitting course. but ultimately the diagnosis comes out as hereditary. So HNPP is a very interesting entity, and you should keep this in mind when patient comes with recurrent isolated neuropathies over a period of long years. Again, as we said previously, lower limbs are commonly affected with neuropathy, but there are certain neuropathies which will affect upper limb predominantly or in isolation. So these can be entrapment or compressive neuropathy like the carpal tunnel syndrome or the Saturday night palsy. Then lead toxicity, porphyria, multifocal motor neuropathy, Tenjia's disease, diphtheria, and Dapson toxicity. So these are again entities where upper limbs are predominantly affected. Third question is nature of sensory involvement. So how the sensory involvement is present? Is it small fiber involvement like pain, burning, pricking, numbness, hyperesthesia, hypersensitivity of skin, autonomic disturbance? These are all related to small fiber symptoms. And in large fiber, we have band-like sensations, very vague and diffuse dull pain, imbalanced gait ataxia, which usually worsens in the dark, and patient may also report what is called the wash basin phenomenon. So this is something where the patient just bends down on his wash basin and he splashes water on his face. And at that time, if he is closing his eyes, he will suddenly become very much ataxic or imbalanced. And that is because of it is kind of a Romberg's phenomenon which is happening. That is called the wash basin sign. And if this is happening, it is very much pointing out towards the large fiber involvement, causing loss of proprioception. So small fiber neuropathies, which are very commonly seen, are diabetes, leprosy, alcohol, HIV, amyloid, and hereditary. So these are common small fiber neuropathies. These patients will present more of positive symptoms, pain, burning, and paresthesias. And on examination, you may find loss of distal sensations like in the feet or the sole of feet. They will have axonal damage and they will have a length dependent, the glove and stocking pattern. There are neuropathies which come with predominantly pain symptoms, where the patient complains of extreme pain in his or her limbs. So first is cryptogenic or idiopathic neuropathy, then diabetes, vasculitis, amyloid, HIV, Fabry's disease, and certain toxins. So these are the ones which usually present as a severe and very severe pain in the limbs. Then there are neuronopathies, or the pathologies which affect the dorsal root ganglia. And they can be vitamin B6 pyridoxine toxicity, cisplatin toxicity, paraneoplastic, HIV, Sjogren syndrome, and at times idiopathic. Next is if there are any upper motor neuron features. So on examination, it is very important you look out for them in the form of tone examination, in the form of reflexes, plantar. So this will point out towards any upper motor neuron features. And if patient presents as upper motor neuron features, then you should see whether the patient has any sensory involvement or it is a pure motor form. So if it is a pure motor form, it is like a Entry-Honsel disease like ALS or SMA, and they can have associated sensory involvement also. So that can be because there is an associated myelopathy, and these are the cases which are called myeloneuropathy. They have myelopathy as well as peripheral neuropathy. This can be asked in your Viva question, that causes of myeloneuropathy. It can also be asked in a different way, where you might be asked that what are the causes of absent plantar with extensor plantar with absent ankle reflex. So causes of absent ankle reflex with extensor plantar, that happens in myeloneuropathy. So this is a very tricky and very specific question in Viva, very commonly asked. So you should be familiar with these entities. B12 deficiency, that is subacute combined degeneration, copper deficiency, Cabeus dorsalis, that is a syphilis, HIV, vasculitis, and Friedreich's ataxia. So these are very important Viva questions for you. Next question is, what is the temporal evolution? How the disease has progressed and how it has behaved. So it can be acute within days to weeks. It can be subacute, and chronic duration is termed as more than 8 weeks. And at times it can be come and go types, that is relapsing remitting. Temporal evolution or temporal behavior of the disease, it is very important to understand the possible etiology behind it. Mostly neuropathies are chronic in duration, and if it might happen at times that the patient just reports a history of few days or weeks, but on examination you might find certain deformities or certain muscle wasting, And if they are present, it points out towards a chronic duration. It might be initially so much less symptomatic for the patient that it was ignored and not reported. And it's only that it has crossed a particular severity, then only the patient has become symptomatic for it and presented to me. So patient might come up as a history of days or weeks, but on examination, if any of these are present, it usually goes into a chronic neuropathy. So with an exception, there are acute onset neuropathies also, that we have GBS variants like AIDP, Aman-Amsan, and MFS, Miller-Fisher. You have vasculitis, ischemic neuropathies, traumatic neuropathies, diabetic cranial neuropathy, porphyria, diphtheria, and brachial inflammation or brachial neuritis. So these are of acute onset. And we have relapsing remitting neuropathies, like again GBS or CIDP, HIV, toxin-induced, porphyria, refsum, and HNPP. Next is any evidence of hereditary neuropathy. So these are a few pointers which will help you to find out whether the given case of neuropathy has a hereditary etiology behind it or not. It is important to identify it clinically, because if we go through the theory of hereditary neuropathy, commonly called the Charcot-Marie-Tooth type of disorders, if you see, there are many genes and many subtypings which are there in CMT. And it is not possible for anybody practically to identify the particular gene if you go for genetic testing. It is very costly and it might not be available that easily also. So hereditary etiology, it is usually a clinical diagnosis, and you might be able to find out clues in history and examination. First will be like patient presents as a very long duration, like duration of 5 years, 10 years, 15 years. That sort of duration might be there. They will be very, very symmetrical. They will not have any asymmetry. They will be very classically symmetrical. Very slow progression. In fact, might be not progressive as well. Patient can report the symptoms of being the same severity in last 5 years or 10 years. Patient might not be that much disabled with it. It might not be painful also. It is just that there might be some loss of function, sensory or motor. Patient will not report any pain, no paresthesias, no tingling, no burning. Then there are deformities, certain deformities which point out towards this hereditary etiology, like pes cavus or hammer toe or pes planus, that is flat foot. These are a few deformities which you should look out for in a case of chronic neuropathy, long-standing neuropathy. Family history of neuropathy can be asked and can be reported by the patient in some cases. But most of the cases, what happens is that hereditary neuropathy has not been diagnosed even in the family members, but they are given certain other diagnoses by other practitioners who are not aware of this entity, and they have been called to have arthritis or polio or those sort of things, but they will never be stamped as hereditary neuropathies. So even if the patient tells you that there is no history of neuropathy in the family, it is very important to ask about history of this type of arthritis or poliomyelitis type of disorders, which are again looking like hereditary neuropathy. Also, if present, the patient family member should be examined by yourself for any evidence of deformities or clinical findings. And if present, it is a very short indicator of a hereditary neuropathy. So keep this in mind. You might get CMT cases in your practical exams. And if yes, make sure you examine the family member who is present along with the patient. Now investigation. So once we answer all these questions, you will have a certain idea what is happening, which system is involved, what is the pattern of weakness, and what are the possible etiologies also. Then there are particular steps you should be following once you are aware about the clinical data. So first step will be now conduction and EMG. Second will be to create a pattern in your mind regarding the clinical data as well as the now conduction data. Then you might come up with etiological investigations, how to proceed, and then final diagnosis. So now conduction study. Now I'll just have one single slide on now conduction because it is a very large thing to understand, but I'll just give you a brief idea that in this diagram, for example, we are supposed to test the median motor now. So an electrode is connected at the thumb, which is the abductor pollicis brevis muscle innervated by median nerve. And then there is an electrode which stimulates this nerve at 2 points. One point, it is proximal to the cell body, that is near the elbow, and the other is near the wrist, which is a distal stimulation. Once the nerve is stimulated, an electrical potential is generated in the nerve, and that reaches the muscle. The muscle contracts, and that contraction is recorded in a recorder which is fitted at the APB. So this will create a graph. If you see on the right lower corner, there is a graph which is generated. The initial flat line is the distal latency. It is the time where the stimulus has been given till the stimulus has reached the muscle fiber. Once it reaches the muscle fiber, there will be a hump which is created, which is called the compound muscle action potential. The height of the hump, it is the amplitude of the wave. That is the first stimulation, that is S1. Similarly, another stimulation is given at the elbow. Obviously, the stimulation is far off from the recording site, so it will take more time to travel to the recording area, and hence the initial flat line is slightly longer. And then another hump comes out, which is again a CMAP, which is compound muscle action potential. And this way, two stimuli are given. Once these two stimuli are given, when we see the parameters which are called the distal latency, the compound muscle action potential amplitude, and the conduction velocity. These are the three main parameters which are studied, and based on the changes over these parameters, we come to know whether the nerve has got an axonal damage or a myelin damage and those sort of information. So this type of study is done over different nerves. Classically or conventionally, we do median nerve, ulnar nerve, radial nerve in upper limbs, and peroneal and tibial nerve and sural nerve in lower limbs. So these are the conventional nerves which can be tested on nerve conduction. Advantage of doing nerve conduction is that first you might be aware about the type of nerve fibers which are involved, whether the small fibers are involved or large fibers are involved or both of them. So that will support your clinical data. Second, it is also important for localization. Localization because, for example, in a carpal tunnel type of patient, a patient comes with pain and numbness in his hand. You are examining the patient and you are aware that the symptoms are in the median territory. Now, median nerve will start from the brachial plexus onto the elbow, and from elbow onto the wrist, and from wrist into the palm. So on nerve conduction, we can ascertain that the median nerve is affected at the level of wrist, and it is not affected proximally at the level of elbow or brachial plexus. So that way, localization can be helpful on nerve conduction. Then whether the patient has got symmetrical pattern or there is an asymmetry to involvement based on the nerve findings. Sometimes patient might not report the symptoms because the neuropathy is not clinically manifested yet. But if we do the nerve conduction study, it can pick up abnormal findings even before the clinical manifestations will come. So patient may have subclinical neuropathy. For example, patient comes with you on like a lower limb symptoms, but we do the nerve conduction of upper limbs and you will find that there is abnormality there as well. So it can pick up subclinical neuropathy. Then based on the amplitude of the graph or the latency or the velocity, we can judge the severity of affection, that how severely the nerves are affected. And based on the severity, we can help in prognostication about the recovery time and recovery parameters. So these are the advantage we have on doing nerve conduction study. It also has certain disadvantage because it is technically challenging test. It is not a very easy thing to perform. It requires time, it requires patience, and it requires the precise anatomical knowledge of where to stimulate the nerves and how to record the graph. Secondly, there is a limited coverage of peripheral nervous system. If we see the diagram here, we are just testing the median nerve from elbow till the wrist and beyond it. Above the elbow, it is difficult to stimulate the peripheral nerves. So certain nerves are such that you cannot stimulate them beyond a certain point, and therefore the whole peripheral nervous system starting from the nerve body or the roots or plexus, they might not be accessible to be tested on nerve conduction study. Next is time-bound test, because sometimes the symptoms might start, but the pathology may not be picked up early on the nerve conduction test. You might be aware about GBS, the AIDP thing, where you have heard that nerve conduction in first 5-7 days might come out as normal. Even with the patient being symptomatic, nerve conduction changes will take some time to appear. So nerve conduction can be normal if done very early in the disease. It has got its own false positives and false negatives. False negatives, as I told you, that it can be done if it is done early in the course of the illness, it might be negative. If the nerve involvement is very much proximal, like in plexus or roots, it might not be seen on nerve conduction study. And false positive can be seen because sometimes because of arthropathy or because of age-related problems or coexisting diabetes, certain neuropathy will be there, which is subclinical, and it might not correlate with the patient symptoms. So there are limitations to nerve conduction, and therefore it is always said that nerve conduction study should be done only and only after you have a particular thorough clinical examination and you have some idea regarding what you are asking or what you are trying to see on nerve conduction study. NCS is not an absolute test. So the results are always and always interpreted with the light of your clinical data. And at times it might happen that you have to refute the findings of nerve conduction study just because you have a very strong clinical evidence of some other problem. So NCS is not a very foolproof or a very absolute disease. It may help, but it should be done in the light of a clinical data. Next comes pattern recognition. So pattern recognition, you first need to know what is demyelinating neuropathy and what is axonal neuropathy. So demyelinating neuropathy, the pattern is proximal and distal. Both can be affected, whereas in axonal, it is a length dependent. So distal is always and always affected first, may or may not be affected by, may or may not be followed by proximal involvement. Onset demyelinating can be acute to subacute, whereas axonal are usually slow progressive. Symptoms, the demyelinating patients, they will have paresthesias, ataxias, weakness. These are the main symptoms of demyelinating problems. Whereas in axonal, they will have more of sensory paresthesias and loss of sensations. In sensory modalities, if demyelination is there, then you have vibration and joint position being affected more than the pain and temperature, and the other way around in axonal varieties. In motor, you will have proximal and distal findings, whereas in axonal, it is always distal weakness. Deep tendon reflexes are absent with demyelination, and they are present, or there may be distal areflexia in axonal variety. Nerve conduction will show prolonged latencies and reduced conduction velocities, whereas in axonal there will be loss of amplitude. If we happen to do a nerve biopsy, which might not be required in all the cases, but if nerve biopsy is done, demyelination will show alternative bands of demyelination and remyelination in a chronic duration. Whereas in axons, there will be loss of axonal areas on particular staining. Prognosis, demyelinating is usually good prognosis. They recover well, recover rapidly, provided it has been diagnosed well and treated well. In axonal variety, there is a slow recovery, and usually it can be irreversible if there is a long-standing damage. And one more thing about demyelination is, if the demyelinating neuropathies are longer duration, then gradually they convert into the axonal variety. So you might have heard or read somewhere about demyelinating neuropathy with secondary axonal damage. So that secondary axonal damage happens in the later course. It might not be present in the initial disease. And the classical examples of demyelinating neuropathy are GBS, CIDP, diphtheria, and multifocal motor neuropathy. And axonal, we have diabetic neuropathy, other toxic neuropathies, HIV, and hereditary neuropathies. Now, these are particular patterns which you should catch on clinical and nerve conduction parameters. I'll not read out everything. You can easily and at your convenience, you can go through these. It is just your clinical findings on the left side, whether proximal weakness, distal weakness, asymmetry or symmetry, sensory symptoms, proprioception loss, upper motor neuron features, and autonomic features. So these are your clinical and nerve conduction findings on the left side. And above are the pattern which can be generated because of variable involvement of these things. So if you develop a skill to identify this type of pattern, it is very easy, and like it is a job of 5 to 7 minutes to pick up the type of peripheral neuropathy. But that 5 to 7 minutes you will be able to develop over a period of time. So it is like a practice. And you should develop your eyesight, you should develop your reflexes and your brain in such a way as to create this type of pattern once you come across a peripheral neuropathy patient. So I'll not read out the whole slide. You can go through it at your convenience. And below are certain examples which will be there. And these are other 4 patterns. So in all, there are 8 to 9 different patterns which can be created out of clinical examination, and they will help you to guide through further investigations, etiology, as well as treatment. So once you know the pattern, like if you have a particular case and you are able to judge the clinical pattern, you have done your nerve conduction, and you now know that which are the modalities which are available or which are affected. Then these are the initial blood tests which are done. Workup of neuropathy is always done in a step-by-step pattern because there are many etiologies which can affect the nerves. So the most common ones are to be tested first. And therefore CBC, ESR, CRP, diabetic investigations, vitamin B12 levels, vasculitis screening, rheumatoid disorders, thyroid disorders, paraproteinemias, and if required, especially in compressive or entrapment neuropathies, nerve or joint ultrasonography. So these are the initial tests which are done in usually all the patients to start with. And I would say almost 70–80% of diagnosis will be happening within these tests, provided they are done appropriately, taken the data from your clinical and nerve conduction examinations. And certain subgroup of patients will require further testing like CSF analysis, for example, in GBS or CIDP, autonomic function tests, toxicology screening or drug levels, paraneoplastic antibodies, HIV, hepatitis or syphilis serology, malignancy, PET scans, MRI of nerve or plexus, genetic testing if you are very sure about a particular subtype, now biopsy or biopsy of lips, skin, lymph nodes or bone marrow if you are searching for that type of etiology. So these are all specialized tests and may not be required in majority of the patients, but you should have them in mind and you should work them up only and only if you have a very strong clinical and nerve conduction type of data with you. And then finally, a small list of drugs which can affect peripheral nerves. Mainly, most of the majority drugs will be affecting axons. They can be toxins like arsenic, lead, mercury, thallium, ethynyl oxide, hexacarbons, organophosphates, and other things. And it can be commonly used pharmaceutical drugs like colchicine, dapsone, antitubercular medicines, metronidazole, nitric oxide, HIV medicines, vincristine, and taxols. So these are common drugs which will be affecting axonal part of the peripheral nerve, and they will present as length-dependent peripheral neuropathy. There are also a few agents which will affect the myelin construction of the nerve, and they are like amiodarone, suramin, like toxins, and trichloroethylene. And neuronopathy, which affects the ganglia. So there will be platinum compounds like 6-platin, high dose of pyridoxine, B6 toxicity, and taxol. So once you have done up your etiological workup and everything, then there comes the final diagnosis. So final diagnosis in a case of peripheral neuropathy. If you are in exam, I think the examiner will expect you to tell the diagnosis in a proper chronology and a proper method. If you are successful in doing so, I am very sure you will be, passing out with flying colors. So this is the format how you describe the diagnosis of peripheral neuropathy. You should tell the timeline, that is if it is acute, subacute, chronic, or relapsing remitting, whether it is symmetrical or asymmetrical, whether motor nerves are involved, sensory are involved, autonomic are involved, or it's a combination, whether there is a small fiber neuropathy or large fiber or both, if it is axonal involvement or demyelination, any particular body area which is affected predominantly like upper limb dominant or lower limb dominant, any other involvement of other areas of neuroaxis like myelopathy, spinal cord involvement, or plexopathy or radiculopathy, and finally possible etiology behind it. So I have just mentioned a common example how you mention this. You can write as a diagnosis like chronic symmetrical sensory motor, small and large fiber axonal neuropathy with possible dorsal myelopathy secondary to systemic vasculitis. So this is your final diagnosis in a case of neuropathy. And if you are successfully able to do so, I don't have any doubts in you performing very well in your exams as well as in your clinical practice. So make yourself habituated to these terminologies, make yourself habituated to pick up clues regarding which systems or which patterns are involved. And it is just a practice about all these things. And if you spend good time with patient, I think in coming months or years, once your exams are done, you'll be doing very, very well in your clinical practice if you have this sort of knowledge. Right. Thank you so much.
Thank you, Bhumir bhai. It was really a very practical class, I will say. There are a few doubts. I think they have been answered. I got in between. But I will just repeat. One is there that what will be your initial workup when you have a case with pattern of mononeuritis multiplex?
Yes. So see, mononeuritis multiplex, if you are able to find out on clinical or nerve conduction study, most of the cases of monomultiplex, they are presenting because of underlying vasculitis. So I think the first line of workup will be more related to vasculitis. It can be rheumatoid disorders, it can be ANCA-associated vasculitis, it can even come up as infection like leprosy or HIV. And diabetes, I would say it can do all types of peripheral neuropathy. So any case, either it is mononeuropathy or monomultiplex or polyneuropathy, I think diabetes testing is a must. Even if the patient tells that he has done a random blood sugar 2 days back and it was normal, you don't agree with that, You have to have an HbA1c report which tells you an average record, average record. And even if in doubt, you can ask for a glucose challenge test also. And one very particular point about diabetic neuropathy is that some patients may present with neuropathy even before the diagnosis of diabetes can be made. Like I have seen patient like 3 years later, the lady presented as peripheral neuropathy. Almost all types of investigations were done. Nothing was found. She was treated symptomatically, doing well on medicine. And after 1.5 years of time, she just went through a body checkup profile and was found to have borderline diabetes. And later on, it converted into a full-fledged diabetes. So diabetic neuropathy can even present before we can diagnose diabetes on blood testings. So keep this diabetes thing in mind. Any case of neuropathy, you always should have a diabetic profile.
Now the second question is, even I also find it interesting that most of the time we order for sural nerve biopsy. So what are the indication to order that? And in case of pure motor nerve involvement, what will be the nerve of choice to biopsy if you want to prove something?
Okay, very good question. Actually, nerve biopsy is a very tricky thing. You should remember that if you are asking or if you are thinking about nerve biopsy, there are few things which you should keep in mind, and only then you should proceed with biopsy. First and foremost, you always biopsy a nerve which is diseased. For example, patient comes with upper limb symptoms and you ask for a sural nerve biopsy, it is not going to give you anything. So if the patient has an upper limb problem, you ask for a dorsal cutaneous nerve or ulnar nerve type of biopsy. If patient has got a lower limb involvement, you should ask for a sural nerve biopsy. So first point is you should have a clinical evidence that that particular nerve is diseased. Secondly, it should not be so much so diseased that it is burnt out or it has got a very severe axonal damage. So nerve conduction will help you out in that, whether the nerve is still alive or it is completely dead. Because if you see the biopsy of a dead nerve, it might not show the etiology. It is just the remnants or the sequelae of whatever has happened. And it will just show a few scattered fibers with no axons at all. So again, that is not going to help you. So selection of nerve is basically dependent on which type of symptoms the patient has come with, what is the severity of that particular nerve being affected clinically as well as on nerve conduction. So accordingly, you should select the nerves. The other part of the question where why is sural nerve done? Like, what is the indication of doing sural nerve biopsy? So practically sural nerve biopsy, or for that matter, any nerve biopsy, it is very, very important, number one, to identify vasculitis. So vasculitis can be short diagnosed on nerve biopsy. So if you have any doubts regarding etiology, nerve biopsy can help you in detecting vasculitis. Second, amyloidosis. At times it happens that the lip biopsy or the tongue or the rectal fat biopsy, they might not be picking up amyloidosis, but the disease now can have amyloid stains if done at a proper center with proper staining. So amyloidosis is another indication where a nerve biopsy is very useful. Third is leprosy. So leprosy can have mononeuropathy. They can have just pure neuropathic form of leprosy. They will not have any cutaneous problems. So in that patient also, if you select the proper nerve and have a proper tissue diagnosis, then you might see the lepra bacilli in that with again proper staining. So I think these are the three main indications where biopsy is very, very useful. Apart from that, diabetic neuropathy or B12 neuropathy or lymphoma or paraproteinemia, they don't have that classical pattern to give you any help in etiological diagnosis. They can just tell you whether there is an axonal damage or a demyelinating damage or some sort of infiltration or inflammation, but it doesn't give the etiological diagnosis. So etiological diagnosis on nerve biopsy, it is only and only seen in these three types. And my personal preference of doing biopsy is only when I'm suspecting these three diagnoses. If I'm not looking into these three diagnoses, I don't order a nerve biopsy without them.
Okay, I also agree. And I may be having a reference bias, but whatever I get in a reference of Monod's multiplex, I get for biopsy done, because my thing is mostly vasculitis. But yes, sometimes we have found sarcoidosis and leprosy also on
exactly.
biopsy.
Yes.
So
sarcoidosis is
I
also,
think yes. So sarcoidosis can present like Monod's multiplex and all.
Okay.
Now this is not more of a I think from the topic, but we get so many time final cases of CIDP. So CIDP, what is the ideal management and workup when they ask we should be telling or we should be doing with our patient?
See, CIDP, I think it is a very underdiagnosed condition. in practical scenario. Exams you might be able to, but when it comes to real life practice, CIDP is a very, very underdiagnosed condition. So you might not hear from everybody what ideal protocol of CIDP management is. So if we go by American guidelines, what happens is first you confirm the diagnosis of CIDP. Diagnosis of CIDP requires number one, clinical history, which should be fitting into the CIDP pattern and duration of more than 8 weeks. Second is your nerve conduction findings, which will point out towards demyelination with or without axonal damage. Third, you should have a CSF evidence of raised protein with normal cells. So these are the three things which will tell you the diagnosis of CIDP. Once you have a diagnosis of CIDP, then the next step is whether it is a primary CIDP, which is idiopathic inflammatory like GBS, or it is secondary CIDP. Secondary CIDP can happen because of diabetes, it can happen because of vasculitis, it can happen because of lymphoma or leukemia type of infiltration, it can happen because of tubercular inflammation. So there are many etiologies which will lead to CIDP type of picture, but they are usually secondary to some systemic disorder. So you might be required to investigate in that line also once you are confirmed with CIDP. So step by step, if you see, CIDP first requires nerve conduction studies. That is the first investigation. Second would be CSF, and then third would be maybe blood reports or MRIs or whatever, depending on which etiology you are suspecting. Once the CIDP part is confirmed, the management is divided into two main portions. One is the induction treatment, and next is the maintenance treatment. So the induction treatment, it can be given either by IV steroids. 1 gram per day is the conventional dose, methylprednisolone. So methylprednisolone 1 gram per day for 5 days. That is one cycle, and that cycle needs to be repeated every 6 months, along with multivitamins and support and diabetic management or other comorbid managements and everything. So one therapy is related to steroids, and second therapy is related to IVIG. IVIG is again given in the dose of 2 grams per kilogram divided over 5 days, and that is the first induction dose. And then subsequent monthly cycles are given, which are given as 1 milligram per kilogram dosage. So it is the half the dose of the induction. So that way the duration of treatment goes on for 6 months. Either you are using IV methylprednisolone or you are using IVIG. Either of them, the duration goes on for 6 months, and they are monthly cycles. And along with that, you should be able to identify the underlying etiology if there is any, and treat that as well. Along with that, the rehabilitation and physiotherapy is also a very important part of the treatment protocol. Plasmapheresis doesn't have a place in CIDP management. In GBS acute, yes, there is plasmapheresis, which is important, but in chronic, there is no guidelines which tells that plasmapheresis is a part of therapy. So in chronic CIDP cases, you have either steroids or IVIG. These are the only two modalities you should be looking
for. Thank you. And this is last question, and I think we both are going to like this. That what are the things, because we see that most of the population has low vitamin B12. So what will be the pointers which tells it is unlikely to be B12 and we should look for something else?
In my personal experience, you should always look for something else. That is the rule of thumb.
I completely agree.
Yeah.
Because, so B12, like having low B12, do not try to explain symptoms with that.
Exactly.
Please take the full history. Yes. Because B12 is very convenient investigation. As a resident, we all have been cheated by that. That once it comes low, we think, okay, it is all due to that, but it is hardly due to that.
Absolutely.
So supplement it, but same time keep your eyes open.
Absolutely.
So I think, yeah, we'll conclude with the same note that neuropathy is a medicine case.
100%, it is a medicine.
Absolutely.
You should have your sound knowledge of Harrison. Bradley and all might be okay. You might not remember them all, but medicine, yes, it is very important.
Yes. Okay, Bhumir bhai. Thank you.
All right. Chalo. Thank you, everybody. Good night.
Yes.